Hello, and welcome to the Clinical Care Options Infectious Disease podcast. I'm your host, Jennifer Swanson. Today's episode features content from an educational program titled HIV-ASSIST, a free online tool for individualized evidence-based ART selection. During this podcast, Dr. Ethel Weld from the Johns Hopkins University School of Medicine in Baltimore, Maryland, discusses the use of HIV-ASSIST to select ART in a patient with comorbidities, drug-drug interactions, and resistance mutations. For more information on Dr. Weld and a link to the full online educational program, including downloadable slides, please visit the show notes for this episode. Now, let's get started and hear what Dr. Weld has to say about using HIV-ASSIST as a time-saving educational resource to inform ART selection.
Thank you so much, Jen, and thanks to everyone for tuning in today. Let's go to our first case. So a treatment-naive woman comes in. She's a 32-year-old woman. She comes to clinic to see you. She has no past medical history, but she was just routinely screened by her primary care physician for HIV and tested positive for the first time. Her labs are normal. She's not pregnant. Her genotype is wild type. Her CD4 count is 450, and her viral load is 357,000. She has a normal BMI. She does not have hepatitis B, and you do have her HLA-B5701 results back, which are negative. So let's take HIV-ASSIST for a spin in determining the best regimen for her. So first we go to the input screen, and we add characteristics that relate to this patient. So you put in that her viral load is high. It's between 100,000 and 500,000. Her CD4 count is above 200. You click that her HLA-B5701 status is negative, indicating she does not have a significant risk of hypersensitivity to abacavir-containing regimens, and that you do not know her tropism because she has not yet had the expensive trophile test to determine that. We go a little bit lower down on the input screen to see that you have the option of excluding antiretrovirals that you feel are not relevant or are unacceptably toxic. And a few are chosen for you in advance. And so you can alter that if you want, for example, to consider some of the drugs that are clicked with the blue checkbox, or you could just leave it as it is. And then you can put in a preferred regimen. Say that you're considering the two-drug regimen Dovato, dolutegravir 3TC for her, under the preferred regimen box. Then you click Submit, and you get this output screen. And the first thing to be aware of is that potential regimens are ranked with color coding and with a weighted score. So you can see that the weighted score, the lower score is better. So a score of 1 is the best possible score. So the highest ranked regimens here are a bictegravir-containing regimen with TAF and FTC, or a dolutegravir-containing regimen with either abacavir or TAF and 3TC or FTC. Your regimen also shows up as highly ranked dolutegravir 3TC below. But they're ranked, they show you in the next column over from score, how many active drugs are in the regimen, how many pills are in the regimen, and what the frequency is, how many times per day. So they're assigned weighting based on multiple factors that are rooted in the primary literature. And you can see that this output, the regimens in dark green are the most highly preferred. It does align very closely with the DHHS and IAS USA guidelines for start regimens for antiretroviral naive individuals. You can see that bictegravir TAF FTC appears on both. This is kind of weighted towards the integrase strand transfer inhibitor based regimens. And also, dolutegravir 3TC does show up with the caveat that shows below that we'll go into in a little bit later. So if you have questions or can't quite remember what the scoring means, you can click on the instructions and expand that out. And it opens this explanation of how you should interpret this color coding. So first of all, something for which there's really evidence against using in a particular clinical scenario is not going to appear on your list at all. The ones with poor evidence will look pink. The ones with moderate to poor evidence will be orange. Moderate evidence is yellow. And strongest evidence is dark green, with strong or moderate evidence being light green. And you can see that the scores increase as you go down in the evidence quality. But going back to the regimens that are listed, say you have a curiosity about any of the regimens that are listed as most preferred by the HIV-ASSIST tool. If you just click on the regimen name, that opens up an education sheet. And that it's a generic education sheet, not specific to any particular product, but basically based on regimens that include 2 NRTIs and 1 integrase strain transfer inhibitor. And it tells you that these are considered the preferred regimens for treatment-naive patients. And you can, if you go down further, get further information about the primary evidence. So the education sheets include these handy-dandy charts that show the accumulated primary evidence from the primary literature. So the studies are listed here, and just to pick one pretty much at random, let's look at trial 1490, which we've highlighted in the red box. And this study looked at the combination of bictegravir and TAF-FTC as compared to dolutegravir and TAF-FTC to basically get at whether the newer NC-BIC was equivalent to the older NC dolutegravir in efficacy. And it showed at the week 96 analysis that 84% of participants in the BIC group, 86% of participants in the dolutegravir group achieved virologic suppression using extremely stringent criteria, and that demonstrated that the bictegravir regimen was non-inferior. If you go further down, there was another trial 1489, that actually compared the bictegravir containing regimen to a regimen with abacavir and the other NC dolutegravir. So this trial, again, showed very similar rates of virologic suppression at the week 96 point. Backing up that the bictegravir containing regimen was not inferior to the other dolutegravir-based regimen that had abacavir in it. They looked at the outcomes of treatment-emergent resistance and renal tubulopathy and did not detect any in either of the groups. And so this is, the data on which it was concluded that this was not inferior. And if you want to look at additional information about other regimens, for example, your preferred regimen, and look at the data behind why that would show up as very highly ranked or with a low score, a preferred score, you can click on it and you come up with the education sheet for dolutegravir 3TC. If you scroll down to the education box, you can see that the Gemini trials, large international paired studies that were randomized controlled trials of a 2-drug regimen of dolutegravir plus 3TC as compared to dolutegravir TDF-FTC. It basically is telling you the upshot of this trial, which I will now show you. So these studies did engage adults with HIV who had never been on treatment. They had to have a viral load between 1,000 and 500,000 copies per ml. But you can see in this graph below where the y-axis is the HIV RNA percent undetectable under 50 copies per ml, and the x-axis is time from randomization. The two curves very closely overlap each other. And you can see that in the 2-drug regimen group, which is the blue curve, 86% met the primary endpoint of virologic suppression. And in the 3-drug group, 89.5%, there was a non-significance difference between them, leading to the conclusion that the 2-drug regimen met criteria for non-inferior efficacy. They also showed kind of overall, actually later presented at CROI, Virtual CROI 2021 by Chloe Orkin, was some data on efficacy at week 144. So the question is this durable? Does this persist? Do you see this even over a very long period of follow-up? And those studies have gone out to week 144 now, and you can see that the efficacy analysis in in the 2-drug regimen was 82%, 84% in the 3-drug regimen, consistent with the overall results of the trials published and shown in the previous slides. But what if you want to go back and change some things up about the patient that, for example, were revealed in further discussions with her after talking to her a little bit longer? So say everything else is the same with her, but she reports to you that she hates pills because she really has trouble swallowing large pills. She's willing to take 2 pills rather than 1, but she requests once daily dosing, and she requests that the pills be as small as they possibly can be. So you click in the input screen under adherence, you can click she would prefer once daily dosing and that she has pill aversion. You'd like the algorithm to prioritize smaller pills. So here I just direct you to this very useful site listed at the bottom left, which just ranks pills by their actual size. And I've organized them on this slide in order of declining size. So the largest is at the top. The smallest is at the bottom. You can see that the combination of dolutegravir and TAF-FTC, those 2 pills, is the smallest option. It's 9 millimeters and then 12 by 6 millimeters. But if you ever want to understand the size of pills, which is something that you don't often get to understand in the clinic if you're not actually handling the medications, this is a very valuable resource. And you can look at the output of HIV-ASSIST and how this is incorporated. So the efficacy comes from the primary literature, but the tool assigns weighting based on factors that are relevant to this particular patient. So on the left is the output that you get if she's selected no options under adherence. We didn't put any pill inversion in. She doesn't care if it's once a day option. And that's the ranking that you get. But on the right is if you put in the 2 adherence factors that we listed, and there you see that the one that comes up most highly ranked is dolutegravir plus TAF-FTC, again, based on the slide that I just showed you, ranking the actual physical size of the pills. Let's go back and change another parameter. What if this woman had everything else the same, except you see that her viral load is 850,000 copies per ml? So you go back to your input, and instead of high viral load in the 100 to 500,000 range, you put in that it's very high. It's greater than 500,000. And you can see that the output slightly changes. Most notably, the 2-drug regimen dolutegravir 3TC falls out of the most highly preferred regimens. And if you're curious about where it went and why it's not there, you can actually scroll down in that output and find your preferred regimen there, ranked 46th in the list, assigned a weighted score of 4. And if you're just wondering why that is, you just click on that regimen, which takes you to the education sheet for dolutegravir 3TC, which shows you the guidelines recommendation and the caveats in the guideline that we discussed before. So the inclusion of dolutegravir 3TC as a recommended initial regimen for most people with HIV is going to apply to all individuals except those with an HIV RNA greater than 500,000, hepatitis B co-infection along with their HIV, or when you're starting a regimen as a rapid start regimen and you do not have HIV genotypic resistance information available yet. So, but to get a little bit more information about this, you can click on the report. And the report will give you side by side, without having to scroll down through all the non-preferred regimens, your the preferred regimen that was selected by HIV-ASSIST and your originally preferred regimen, dolutegravir 3TC, in an inset box. And it will show you the reasons why it was demoted. So in this case, it has an excellent base score, has a good score for pill burden. It's not penalized at all for mutations, but it adds 3 points, penalizing it heavily in the setting of a non-suppressed viral load and a viral load higher than 500,000, leading to a weighted score that really significantly demotes it. let's go back and say that the thing that you changed, her viral load is back down to 357,000. She's still a treatment-naive woman presenting to you for the first time for care. And she reports to you that she's sexually active with one male partner with whom she's trying to conceive. So you go into the input screen and you input that she has the comorbidity of pregnancy, which is, for the purposes of this algorithm, encompasses preconception all the way up to, or less than 8 weeks from the last menstrual period, all the way up to delivery. And you can see that the output includes this red exclamation mark. And this red exclamation mark denotes that there is a dosing caveat. There's some different way of administering it for this patient in this particular clinical circumstance that merits attention from you. And you can see that what actually is giving us the dosing caveat and this exclamation point in this case is the fact that this is BID dosing, because the dosing of darunavir and ritonavir in pregnancy has to be BID to achieve exposures that are similar to non-pregnant adults taking it once a day. If you need more information about this, you click on additional information, which again brings you to information about the preferred regimens in pregnancy. So what's listed most preferred is dolutegravir, bacavir 3-TC. Also on there is dolutegravir plus TDF-FTC and dolutegravir plus TAF-FTC, which is slightly less preferred. And looking at the data, you can see in the dolutegravir box that it's currently a preferred anchor drug during preconception or at any time during pregnancy. And it tells you a little bit about the history of how this recommendation evolved. And I'm going to go into that on the next slide. So the recommendations from the Department of Health and Human Services in this country on ART in pregnancy and people who are trying to conceive include preferred regimens that are dual NRTI backbone plus an INSTI or plus a boosted PI. And you can see that alternatives are efavirenz, rilpivirine, also listed as an alternative, but with increased accumulating data supporting its use in pregnancy with the FTC-TAF. And regimens that are really not recommended in pregnancy, either on the basis of insufficient data in pregnancy, such as bictegravir, doravirine, ibalizumab, temsivir, et cetera, or because of PK concerns, such as COVID-boosted regimens, are excluded from the HIV-ASSIST algorithm. But going back to this question about dolutegravir, so there was a study called the SIPAMO study that took place in Botswana during a nationwide rollout of dolutegravir across adults of reproductive age. And it showed initially, in an unplanned initial assessment in May of 2018, an increase in neural tube defects among infants born to women taking dolutegravir at the time of conception. This increase was to about 0.94% in the dolutegravir containing group, as compared to 0.12% in the group on ART that did not include dolutegravir. So there was initial cause for concern and guidances issued from the major regulatory and guidelines agencies. But then when they analyzed the data collected through April of 2020, it showed that the neural tube defect prevalence with dolutegravir-based ART really leveled out at about 0.19%, which was not significantly different from the 0.11% observed among women on non-dolutegravir containing ART, as compared to 0.07% among HIV-negative women. So the conclusion was, in fact, there is not a cause for safety concern for dolutegravir in pregnancy. The reason why it was so important to look at why we should really re-examine this kind of alarmism around dolutegravir is that the most important thing in pregnancy, or one of the most important considerations, is the prevention of transmission of virus vertically from the mother to the infant. And there's a about a 30% risk of acquiring virus if the mom is not treated during pregnancy or peripartum. And then if the child's born with HIV, they have a 50% risk of death within their first 2 years. So the fallout of not having a suppressed viral load in pregnancy is large. And you can see that dolutegravir really is far superior in achieving virologic suppression quickly and efficiently in pregnancy. So on the y-axis is HIV viral load suppression. On the x-axis is weeks from randomization. The blue curve is dolutegravir. The red is efavirenz. And you can see that there was a difference in median time to suppression. It was 4 weeks to suppression with dolutegravir and 12 weeks with efavirenz. In terms of virologic failure was less common in the dolutegravir-containing regimens than in the efavirenz-containing regimens. And they also took a look at the safety in this dolphin study and saw that there was not a significant difference in safety between the two arms. They did have 3 cases of transmission of HIV to the infant in the dolutegravir arm and 1 transmission in the efavirenz arm. And the dolutegravir arm transmissions were attributed to transmissions that occurred before these women in the 3rd trimester of their pregnancy presented for the trial. And in the efavirenz arm, it was in a woman who was breastfeeding. But the take-home points about the overall algorithm is that for initial ART selection, this is, a great tool because it's free, it's online, it's guidelines-based, it supports you in choosing a regimen for the individual patient who's sitting in front of you, and based on their individual adherence, particularities, concerns, and patterns, and preferences. And it helps you make informed decisions by citing the primary literature, for example, the Gemini trial with dolutegravir 3TC, excluding patients with a viral load greater than 500,000, and the Sapama trial data, and extremely crucial follow-up data in women on dolutegravir in periconception and pregnancy. And it is quite time-saving because it can be used at the point of care. So let's switch gears a little bit and talk about HIV seroconversion during intermittent PrEP use. So what if at this point, all the other parameters are the same, but she tells you that she's actually been using TDF-FTC PrEP and has been intermittently adherent to that regimen? So this actually raises concern for she's been intermittently adherent, so had risk factors for HIV, which is why perhaps she had chosen to take PrEP, but there's a concern that she could have seroconverted with HIV and been on subtherapeutic, suboptimal ART treatment for a while afterwards, which is a precondition for resistance development. So the way that you would put this in is you would click that she had intermittent adherence, under adherence, and then you would put TDF-FTC under treatment history as her prior regimen. So being on Truvada-based PrEP is her prior regimen, even though she's treatment naive from the perspective of HIV treatment. She's been on TDF-FTC for prevention. And what that does is it imputes potential problematic mutations that are associated with TDF-FTC. So you can see the output on the right shows you that most of the choices have 2 active drugs. Most of them can be done once a day. The options include both INSTI-based regimens and PI-based regimens. And you can see if you click increase prioritization of at least 3 active drugs, you will see different options appear that will more highly rank regimens that contain at least 3 active drugs. If you want kind of more information about what happened to my 2-drug regimen and why did that drop out, you click on the report tab, and what it tells you about your originally preferred regimen of dolutegravir 3TC is it was excluded due to a presumed presence of a high-level mutation M184V, but without maybe a fully active tenofovir, if you're assuming resistance to both VEF and FTC. Also, regimens with a very high barrier for resistance were prioritized, so that's taken into account. And having a non-suppressed viral load, that would penalize regimens with fewer than 3 active drugs. So let's switch briefly for our last case to the treatment experienced gentleman. So this is a gentleman with HIV who comes in to see you. He's been, for the last little while, on elvitegravir boosted with cobicistat, as well as TAF-FTC combined into a single tablet regimen. He has had periods of housing insecurity, and he recently did obtain housing, but he's been in and out of care. He has not at this point been seen in care for his HIV for 9 months, although he still appears to be picking up his ART prescriptions at the pharmacy. You can see his parameters at the right. His CD4 count is 85. His viral load is 31,000. You have some mutations that are present on a genotype that you drew out of concern for this non-suppressed viral load, though reportedly on meds. And so the review of the current regimen is below. So this regimen that he's on was FDA approved in 2015, replacing the previously approved drug, which is still available on the open market as well, but had TDF instead of TAF. And it contains a pharmacologic booster to maintain levels of elvitegravir in the therapeutic range. But along with that come many drug-drug interactions, GI side effects, and other things that you might want to avoid. It's recommended to be taken with food, which is another issue. People with unstable housing may have food instability and food access issues. And it has a low barrier to resistance among the INSTIs. Here's his treatment history. So you elicit from him that he was initially suppressed in 2012 on efavirenz TDF-FTC. Then he was off ART for a few years, then placed on the prior single tablet regimen of elvitegravir, Cobi, TDF-FTC. And during that period of time, he had HIV viral loads measured on 4 occasions. Once it was undetectable, then 140 copies per ml, then 287, then undetectable again, and then off ART for a few years. Suppressed on a new regimen of elvitegravir, Cobi, TAF-FTC with HIV RNA now, 30,000 though. And his genotypes are shown at right. And let's go into those mutations a little bit more. So on the left is the M184V mutation, which is a mutation in the HIV reverse transcriptase gene. And what it does is reduce susceptibility to 3TC and FTC by 100-fold, but slightly increases susceptibility to tenofovir. So sometimes you see people who have this regimen, who have this mutation, still taking FTC or 3TC because it's often in combination with TDF or TAF. And you can see displayed here the resistance level to the various drugs conferred by this mutation. On the right, we have the E92Q, which is a common INSTI mutation selected in patients taking raltegravir or elvitegravir, which is what he's taking. And it does reduce your susceptibility 5 to 10-fold for raltegravir and 30-fold for elvitegravir, with the rankings of the resistance displayed below. And let's go to the DHHS guidelines for choosing a new regimen when you have someone presenting to you with this picture concerning for virologic failure. It's quite complex. It's not a bad idea to engage expert consultation when you're looking at this situation. And in general, the optimal approach should be a new regimen with 2 and preferably 3 fully active agents, preferably with a high barrier to resistance. The evaluation of people with virologic failure should include all the resistance test results you can dig up or send, viral load and CD4 counts and levels over time, consideration of whether there's a notable drug-drug interaction that could be dropping his levels, or drug-food interactions. For example, food is needed to absorb drug and he doesn't have consistent access to food. assessment of drug tolerability, their adherence patterns, because the most common reason for having a detectable viral load is non-adherence, as well as all the different twists and turns of their ART history. And optimally simplifying a regimen does improve adherence. So the way that you enter in antiretroviral mutations and other kind of factors specific to the patient, here at the upper left, there's a little box that allows you just to free text in the mutations that you get straight off of the genotype report. And you can also put in the current regimen down here at the right, which is the COVID-boosted L-bictegravir-based regimen. When you put in those outputs and his CD4 and viral load parameters, the regimens that come out most highly weighted are COVID-boosted darunavir with TAF-FTC or ritonavir-boosted darunavir with TAF-FTC. Let's go into a little bit more about why that is. So if you click on the additional information tab, that's actually going to explain what penalties were assigned based on the mutations. And this takes you directly to the Stanford database readout without having to open other windows, log into other sites, and put in all the mutations yourself into the separate tab. This is integrated and embedded into the app and shows you the relative change in susceptibility for each of the mutations that you have input into HIV-ASSIST. And what if, when you talk to this gentleman, you kind of discuss and probe a little bit further and find out that his adherence actually has really been off and on. He's picking up his meds from the pharmacy, but it's variable how often he takes his meds. So on the left is what the output is if you select no adherence options. There's only 2 regimens with favorable weighted scores. On the right, if you put in that he has intermittent adherence, then you have some regimens displayed with stronger evidence for kind of adding an INSTI to the PI-boosted regimen. And looking into that a little further, you can click on the education sheet, and it basically tells you that COVID-boosted darunavir has been studied in the Emerald study. And let's go into the Emerald study on the next slide. So this was a study of switching in virologically suppressed patients from a boosted PI plus TDF-FTC to COVID-boosted darunavir with TAF-FTC. And they either did an immediate switch to the COVID-boosted darunavir with TAF-FTC, or they did a late switch at week 52, and they compared outcomes. So they enrolled greater than 1,000 virologically suppressed people with no prior virologic failure. 15% of them had failure on other ART, but just not on darunavir. And 4% had an M184V on genotypes that were archived. And so you can see that kind of matches the patient that we're looking at. And the primary endpoint was protocol-defined virologic rebound through week 48, defined as confirmed viral load greater than 50 copies, which was seen in 2.5% in the immediate switch arm versus 2.1% with late switch, confirming non-inferiority. So the immediate switch was non-inferior to a late switch. They did not see any primary resistance associated mutations emerge, and that is the reason for the recommendation. So recalling that red exclamation points signify additional warnings or dosing caveats, we look below and we see exclamation points next to these 2 regimens that are still in green. You click on the exclamation point, and that links you to the dosing info tab on the education sheet and tells you that the reason this exclamation point is here is that dolutegravir must be dosed BID, so twice a day in people with integrase resistance. Why do we think that? We think that because of the results of the Viking 3 trial. So this looked at dolutegravir BID in previously treated patients with resistance to raltegravir or L-bictegravir. And it was a single-arm study. And it was to determine the efficacy of BID, twice a day dolutegravir plus an optimized background regimen, in treatment-experienced people with HIV who had some resistance to raltegravir or elvitegravir and a non-suppressed viral load. They included an initial 7-day functional monotherapy phase with dolutegravir 50 BID just to see how much the viral load dropped on functional monotherapy. And then they followed that with the optimized background regimen co-administered. But the primary endpoint of mean change in viral load from baseline to day 8, so after just 8 days on the BID dolutegravir, there was a 1.4 log drop in the viral load. And again, this shows the overall results of virologic suppression on this BID dolutegravir plus optimized background regimen, 69% at week 24, 63% at week 48. In participants who had no Q148 mutation, it was higher, approaching 80%. But 67% who met criteria for protocol-defined virologic failure through week 84 had this Q148 mutation at baseline or by history. The take-home points of this portion are to avoid earlier generation INSTIs in patients who may have difficulty with adherence because their barrier to adherence is lower. And that virologic failure while on COVID-boosted elvitegravir TAF FTC can result in mutations, including the M184V, the E92Q, resistance-associated mutations, and that's going to jeopardize the efficacy of other INSTIs. And require that if you use INSTIs, they be BID dosed. But that HIV-ASSIST really does provide you with guidelines-based decision support at the point of care regarding selecting ARTs in individuals who are treatment experienced who have some resistance. The pearls, such as a Dunavir-based regimen, can be used in the presence of these other resistance mutations that don't impact PIs. And then if you use dolutegravir in the presence of INSTI resistance, you should dose it twice a day. All right, perfect. So at this point, I'm going to turn it back over to Jen. Thank you very much for listening.
Well, thank you so much, Dr. Weld, for that wonderful presentation. And we've had a few questions, kind of similar to questions we've had at the other webinars. So one of the things people are wondering is about entering that mutation data. Are there specific formats that you have to enter it? What happens if you don't enter it correctly, et cetera?
Yeah, so if you just free text in M184V and separate it by a comma from other mutations, I've found it to work just fine. There are some little instructions right below the free text mutations box to kind of help you in entering mutations, but basically really free texting in the mutations that you see in your genotype reports has worked fine in my experience. Now, sometimes you'll have a mutation that says M184V / something else. So that mutated amino acid can be different. It can be one thing or another thing. And what I do in that case is just enter in the M184V, comma, and then enter the M184I or whatever the slash is. So that's how I would approach that.
Okay, thank you. That sounds like a great approach. And then other questions we have are the difference between the treatment history box and the current regimen box, and what if you don't know treatment history?
Yeah, so great question. So if you don't know treatment history, you can just leave it blank. It's totally fine to not know treatment history. Many times you're seeing people in clinic who you can't get records on and they have no idea what they've taken. And so that is the reality. But if you do have some information about treatment history and you enter it into that box, it does assume that it was a failed regimen, and that's why they're not on it anymore. So that's a conservative assumption, but one that is often reasonable clinically. You have the option of using the current regimen box just to tell what a person is taking at that moment when you're seeing them, what their med list tells you they're on. And if you also enter in that their viral load is non-suppressed, it assumes that that current regimen is a failing regimen. So there's kind of two, and it will impute the mutations that go along with failing on that regimen. So there's kind of two ways around putting in past treatment that's not been working for the participant. Does
Okay, that's great to know. And what about the desired regimen box? What if you don't have a desired regimen because you're just really kind of information seeking, doing some, broad strokes background research? And what if you put it in and HIV-ASSIST doesn't agree with it?
Yeah, so that's the great thing is it's quite flexible. If you have a desired regimen that you're considering, that's awesome. You can put it in. And it's wonderful if it tells you that that regimen is not the best idea, because then you've learned something that benefits your patient. If you have no idea what they should be taking and you have no desired regimen, nothing that you're considering, just leave it blank. That's completely fine. It'll still give you a first line output that's guidelines supported and rooted in the primary evidence.
Well, that's great. That's simple enough. So we have another question here. Could the HIV-ASSIST tool be taken to Africa or other low middle income countries and be modified for local needs? This is an extremely useful tool.
Yeah, so that is one of the things that I think is the most exciting things about this tool. It's free. You can use it anywhere where you have an internet signal or an internet cafe where you can somehow get connectivity. So this can be taken anywhere in the world where you have a signal. And the only thing that you need to use it is a computer or a smartphone or a phone that has capacity to get on the internet and an internet connectivity situation that's favorable. So I think that this can and should be widely used in the developing world and in care settings that are kind of unable to access tertiary care and subspecialty care. And in a way, I think that's what makes it so democratic a tool.
Well, we're out of time, but that's a great place to end today's discussion. Thank you very much to Dr. Weld and to our listeners for joining in. As a reminder, to view the full educational program about HIV-ASSIST on the Clinical Care Options website, click on the link in the show notes. And please check back regularly for more episodes on important infectious disease topics. Thank you again and have a wonderful day.